Welcome. I'm Adam Wood. I am your teacher today for physio. I also do pharmacodynamics, which we'll have on Friday. Friday sounds right. Anywho. So everyone's here for physiology, right? No one here for underwater basket weaving or no, yeah. Okay, good. So just to tell you a little bit about myself, for those of you guys don't know, or have you guys heard anything about my courses or myself? Any rumors or? That's okay if they're bad. I understand. That's fine. So basically what we're going to do here is cover kind of the basics of body function. Obviously, you're going to get anatomy as well, and this works very well in tandem with that course. So we're going to kind of get the function here where I get the form over with Professor Austin. Just a little bit about myself. I have a PharmD, which is not an agricultural degree, which I was misled to believe when I went into school. Wrong farm. But yeah, so I'm a pharmacist, right? So you may think like, well, what the heck is a pharmacist teaching me about physiology? You're going to see there's a lot of really good parallels here to understanding how drugs work in the body. You have to understand how the body works at kind of a baseline. And then when you get into clin pathophys, you'll understand how the body goes wrong. We'll talk about that a little bit here, but really we're trying to focus on normal function here. So my background is obviously in pharmacy. I graduated from UF, I think, in 2010. After that, I really got a big love for clinical toxicology, right? Anyone know what that is? Any idea? Poisoning, snake bites, all that kind of good stuff. Being here in Florida, we have a lot of snakes, so that's good. So any of you that are not Florida native, guess what? We got snakes. Be careful with them. Don't pet them. It's a bad idea. But anyway, so I really like clinical toxicology, so I went ahead and did a 2-year fellowship up in Jacksonville at UF Health is what it's called now. It used to be called Shands Jacksonville. I did a 2-year fellowship in clinical toxicology and emergency medicine. I did that at the hospital along with the poison center they have up there. We'll talk about poison centers later. But I did 2 years of that, really enjoyed that, and then afterwards I needed to find a job, and so as you guys will need to do one day, hopefully. And so I needed to go somewhere, and actually Nemours Children's Hospital. Anyone familiar with that hospital? It's relatively new over in Lake Nona side of town. It's a very nice side of town, very up and developing. But back in 2012, it was all cow pastures and like swampland. Nowadays, when you drive out there, you see it's a lot different. There's a lot of new buildings and things like that going up. There's the VA, there's UF College of Pharmacy, there's all kinds of good stuff out there. Anyway, so I went ahead and they needed to start up their hospital in 2012, and so I actually joined there as their first ER pharmacist, because again, that was kind of my specialty. And so there I did a inpatient clinical toxicology service, worked in the ER for probably 4-ish sort of years. I moved into more of a administrative sort of role. Didn't really like that so much, and I've been teaching for Nova for probably 3 years at that point. So went ahead and moved into teaching full time. However, as you'll see with your other professors, we all get 1 professional day a week, and so most of us use that to work clinically. So for instance, on Mondays, you'll never see me here because I will be over at Nemours. I actually work there in the pharmacy, helping to take care of those children. So that helps us to stay relevant from a clinical standpoint, so that way I can come in on Tuesday, talk to you guys and be like, hey, I saw this really awesome case. There's this kid that got put on ECMO because he got X, Y, Z going on, and it helps to kind of give you some real world examples of why you're learning all this stuff, how it can apply back to your patients eventually. So that's my background a little bit from a clinical standpoint. I have 2 children at home. I'll probably talk about them quite a bit. A 2-year-old turned 2 on Friday, and a 5-month-old. So if I appear especially sleepy, that is why. It's because I probably did not sleep well the night before, as in last night. Which is okay because this is the 8 o'clock class. People tend to like me at 8 o'clock session because it helps them to kind of get a little snooze in before the 10 o'clock session starts up. That's okay. I do record all of my videos, all my lectures here. So this is recording currently. So I post these up to YouTube usually the same day. So that way, if you miss something, if you're like, what the heck did he say about this? You can go back and just look at the video, right? Also, you can go back and say, hey, you said this totally wrong. And I'll be like, there's no way I said that wrong. Go back to the video and be like, oh yeah, I said that wrong. Okay, so let me go ahead and clarify that, right? Which is, to another point, we are very fallible here. Your professors can get things wrong just like you can. And so it's important to take that with some a grain of salt. Things that we say, we try to speak as best as we can, but sometimes we'll screw up, and that's okay if you call us out on it, but please do so in a respectful sort of manner. That goes for the same thing for test as well. If you have a question about a test, test question that came up and just like, I really don't feel like this is right, we can have that conversation. And that's why we always try to have a very open door policy. Just come by our office and just talk to us, right? And keep in mind, try not to play the professors against one another, because you're going to say, well, Dr. Wood said this, and then Professor Austin said this. That's okay if there's a little bit of disagreement there, because guess what? In medicine, you're going to have lots of disagreements. And so think about the perspective we're coming at it from, and we'll try to meet you guys halfway to make sure you understand why something is or is not the way it happens to be, right? Anything else? Any questions so far? Yes?
How do we find your lectures on YouTube?
You will find them on Canvas. I will, whenever you get a link to Canvas, I might also send out a link to my Google Drive buddy here for today at least. But you also, I don't know if you can actually search me on YouTube. There's a lot of Adam Woods out there, as it turns out. However, once you get the first link, if you subscribe, feel free to. That way you can always go back and look at my stuff. And actually, if you wanted to, all of my pharm lectures for the past couple of years, my physio, epi bio, if you have insomnia, need to go to sleep, that is the channel for you. Let me tell you what. There's like, you know, the chill hip hop beats channel you can like use to study with, right? Anyone familiar with those channels? I have like the insomnia video channel, so like people use that quite a bit. Anywho, right. So I'll usually post those at the same day, but if it's like on a Friday or something, like give me the weekend or so, unless like a test coming up. Generally, they'll put my test on Mondays because they tend to be a little bit more rigorous. You may have heard that about me, but that will give you the weekend to study for. So we try to do as much as we can, especially when we get to pharm in the next semester. You're going to appreciate having those on a Monday. Students really like that when we did this last semester. I really encourage a dialogue between us. So if you have a question, feel free to answer. Like I don't really care to stop what I'm doing. I can stop me in the middle of my train of thought. And we can talk about things. I really prefer that. Otherwise, I'm just going to be talking at you for 2 hours straight, and that gets boring. That's no fun for anyone. And other things as far as like, you know, again, I have the 8 o'clock session. I understand stuff happens. There's traffic. I'm coming from St. Cloud. If anyone's familiar where that's at, you know, it's near kind of the Lake Nona area. It's like a 45-minute drive on a good day, but you know, with school happening and accidents and things like that, stuff happens, right? So I understand that. You know, you don't have to make a big deal about it coming in and you know, giving in kind of excuses. It's fine. If you walk in late, it's fine. You can watch the videos. You can catch back up. It's no problem there. If you have to go to the bathroom, you don't have to raise your hand and ask for permission. Just go to the bathroom. It's fine. I try to be very respectful of your time, though, so I will try to take a break right at 8:50 and then have a 10-minute break. We'll come back and then finish up at 9:50. I generally use most of my time, unless it's right before a test, and then we might finish up a little bit early. So, also, I like to do Kahoot reviews for my test. Anyone heard of Kahoot before? Kahoot's very cool. If you look it up, it's kind of, I think, originally designed for more like primary education, so like elementary school, middle, high school. However, it works great for our purposes here as well. And so it'll be like a little quiz, basically, where we'll come in. I will post a quiz up there. You will log in from your computer, iPhone, whatever you have, and basically we'll take the quiz together, and we'll go through and you'll select your answers. We'll kind of figure out where the weak points are, because like, you know, there'll be obviously 1 right answer and 3 wrong answers. We'll find out, wow, like half you guys thought the wrong answer was correct. Let's dig into why that is, and we have a little discussion about it. And I think people really enjoyed that, and that'll also be recorded for your purposes. And you can go back and retake the quiz later if you like. Anyway, these dates should be correct as far as when the tests are going to be. This class is only based on 4 exams, all equally weighted. They're non-comprehensive. So, you know, again, when we finish section 1, that's all going to be the stuff for test 1. Those dates, again, should be accurate there. You need to get at least a 75 average to pass the course. Again, this is my 2nd time teaching this, and I had no one fail the first time. So hoping you guys are going to continue on with that, make it a trend, right? Hopefully, yes. Anyway, it's so funny when Dr. D. Marquardt was talking about, you know, failing as being a first attempt in learning. I was like, yeah, that's true, but hopefully it doesn't get to the last attempt in learning anymore. Anyway, basically though, with a test failure, just because you fail 1 test doesn't mean you have to come back and do a retake or anything like that. It's based on your average at the end of the test, or at the end of the course. So if you have below that 75, then you guys have heard about the CSP, or the Committee for Student Progress. It's not punishment, but Committee for Student Progress. We kind of figure out kind of where the issues lie with, you know, students' study habits and things like that. If I call you patients on accident, just bear with me. But, you know, we do retest as well. So we may do like a comprehensive retest if you end up getting less than a 75. So just be aware that no one's going to need that, but if it happens to happen, then we'll cross that bridge when we get to it. So, okay. Let's see, 3 credit hours. Here's the, so the book you can find, please, hopefully no one bought the book and the hard copy version, but if you go to, you can find it online, unless you really like hard copies, but if you go online, go to, everyone been to the Nova HPD library website? Get familiar with it, get used to it. There's a lot of really good references on there, but if you go to databases, clinical key, and then go into the books, and then you can find this Guyton and Hall textbook of medical physiology. That's where we're pulling all of the lecture material from. And here's the chapters of the book that you can kind of reference back to if you need to. Again, you don't have to go through and read the book verbatim. However, it can be very useful to help get some supplementary information and some additional understanding. I try to make sure that my testing material all comes from the lectures here, right? So again, if you can get through this, you have a really good understanding, and you do really well in the review, chances are you're probably going to do good on the test, right? So shouldn't be any issues there. Okay, so again, this class is going to be basically going over normal physiology, the normal functioning of the body. We'll talk about disease and talk about when things get out of that normal. However, this is the main function here. So this will kind of set you up for, your Chem Pathophys course that'll be coming up next semester. This will get you set up for CMS when you're actually getting into specific disease states. To know how things function normally, you have to understand that before you can understand how things kind of go wrong, essentially. And some people will complain that this is, some of my reviews from the first time I taught this, they said, oh, it's just like another farm course, it's like another drug. Because again, that's my perspective, that's where I'm coming from. So I'll mention drugs quite a bit. It won't be tested on that specifically, but I'll talk about how we can change the normal function by introducing things like drugs. And so that'll be very useful, especially when we get into the farm courses. People really appreciate having this background because it informs so much of what goes on in upcoming courses, essentially. So anyway, so any questions so far? Any comments, quips, quibbles, quotes? Fantastic. All right, so we're gonna get started. And again, any questions, just raise your hand. We'll talk about it. No worries. All right, so basically the section 1, this will be the first chunk, the first quarter of the material we're going to be covering. We're going to start at the very baseline because everyone here has taken anatomy and physiology before, correct? Hopefully, because again, that was probably a prereq to get into here. So hopefully everyone took it. You may not remember it, but you took it at some point. I took it at some point too, and so again, this is something I have to go back through and make sure I understand everything appropriately. Because again, some of the details, some of these kind of basics, you kind of gloss over when you actually get into real clinical medicine here. But we're going to start at the baseline, make sure everyone can kind of come up together, and make sure everyone is at the same playing field. So you may see this first PowerPoint, like, this is super basic. Why are we covering this? I'm going to try to make it from the medical perspective, which you may not have gotten in your original A&P classes. So that'll be at least something new, at least a new perspective on things. We'll talk a little bit about things like chemical composition. So again, going back down to the atomic sort of level there. Again, we're not going to get super heavy into the chemistry. It'll be just very basic stuff. I'm not going to ask you what's the energy of activation of this reaction. Not what we're covering there, but it's going to be like, okay, what's the atomic weight of this thing that has 23 protons? Things like that, kind of basic stuff. We're going to do things like cell structure, enzymes. We'll talk about energy, how we actually produce energy. Anyone know what the powerhouse of the cell is? Oh man, good. I don't have to cover that in the class. I can cut that out. Yeah. If anyone knows anything about physiology, it's like the mitochondria is a powerhouse of the cell. We'll talk about cellular respiration, where the mitochondria is very important for things like aerobic respiration. And then we'll cover things about the cellular environment, also the extracellular environment, how those things communicate with one another. We'll talk about electrolytes. We'll talk about fluid balance, all that sort of good stuff to help regulate our bodies. So we'll then talk about endocrine, and then we'll get into the sensory stuff. We'll find that the neuro information is going to be kind of towards the tail end of the class. That'll kind of bring back in a lot of the sensory stuff. We'll go over the basic senses up front. So we'll talk about vision, hearing, tactile sensation, all those sorts of things will come up in that section there. Okay, so again, we'll talk about today, basic organization, function of the cell, basic function of the body. All right, again, I'll go over the objectives too in depth there. But let's talk about body function. We're going to talk about different types of tissues here a little bit later. But one of the big core concepts of physiology we'll talk about, especially normal, is going to be homeostasis. Can anyone tell me what homeostasis is? Balance. That's a good way to talk about it. And again, I'll ask a lot of questions. I'll say like, hey, can anyone tell me what this is? And really the thing I'm trying to get at with that is not to see that you have a perfect understanding of the situation or the concept, but like, how do you explain it to someone who has no knowledge whatsoever? Because one of the biggest things you do as a PA, as a pharmacist, as a physician is you're going to be educating your patients, right? You can tell them, hey, we're doing this procedure and we're going to give you this medication. They need to understand why that is. If not, then they may do things incorrectly, or they may not do it at all because they're like, well, I don't even know why I'm taking this medication. It just makes me feel bad, right? So education is really important. Being able to take things back down to a basic level to people who have no medical knowledge is really, really important. So for instance, if I tell someone you have hypertension, what does that mean to you? You have high blood pressure, right? A lot of people may not know what that term even means. Like, so, and I'll mention this quite frequently, but I'm from Putnam County. Originally, anyone familiar with Putnam County? Very few people, exactly. So basically, if you take Gainesville, if you're looking at the map of Florida, Gainesville, here's St. Augustine, Putnam County is right in the middle of there. A lot of meth labs and not many teeth, this sort of thing. Anyway, but that's where I'm from, and I did rotations there. Palaca, Florida is where I did my ambulatory rotation, and we were doing INR clinics, and basically we were giving a drug called Coumadin, it's a blood thinner, to patients who had atrial fibrillation, and we had to explain these things to them all the time, and be like, they don't understand what hypertension means, but they say high blood. If you're high blood, that means high blood pressure to them, right? That's just what they know it as. So being able to understand these things at a very conceptual basis and being able to bring it down to their level is super, super important for patient education. But as you said, balance is very important here, and this is homeostasis at the minimum. So basically, we're trying to keep things within a norm, right? Now, for instance, with your blood pressure, is it always going to stay one blood pressure all the time? No, it shouldn't. And what's a normal blood pressure? Anyone know? Stop their head. 120/80, right? It's a perfect blood pressure right there. You're not always going to stay there, though, right? There's going to be some variation there, and it's important to understand that there's ranges for everything, right? We want to keep within that range, but when you deviate outside of that, that's where we're going to have what we call these compensatory mechanisms. These things that are going to come in and try to bring whatever is out of whack back into the normal range there. So, for instance, hydrogen ions, which help to contribute to things like serum pH, very, very tight control of that. Normal serum pH is, say, between 7.35 to 7.45, right? Not a very wide range there, and there's a lot of disease states that can kind of knock you way far out of that. So for instance, anyone familiar with the term sepsis? What is sepsis? It's a blood infection, basically, and again, it's a body-wide sort of inflammation, but that very often will cause hypotension, which can lead to things like acidosis. And when you get acidotic, everything kind of goes out the window. Things like proteins don't function well, blood pressure, again, I mentioned, goes out of control. So you have to understand there's narrow ranges here for a lot of these things, and we want to maintain it within that range. Serum sodium, for example. Serum sodium should be anywhere between 135 to 145. It's not important to memorize these numbers right here specifically. If I give you a question, I will put what the normal range is in parentheses. So I'll say like, hey, patient comes back with a sodium of 110. Here's the normal range. What do you interpret that to be, right? So you need to be able to interpret those sort of findings. Because again, memorization is not quite as important here as the concepts. But anyway, serum sodium 135 to 145, and that will stay pretty rock solid despite having wildly different intakes of sodium. So for instance, what was this past weekend? Memorial Day. Did anyone happen to have a barbecue? What do you eat at barbecues? Chips, a lot of salt, smoked meats, hamburgers, hot dogs, a lot of salt there, right? Chances are you didn't come up with a sodium of 160. Right? Because we have ways of dealing with that. We have ways for the kidney to function with that. We have hormones that the brain will secrete to help deal with that, to make sure that you don't go outside of those ranges, right? Now, there's going to be a certain point where you kind of fall off that threshold. So, for instance, if I were to just eat a pound of just straight salt, that would obviously overwhelm the body's ability to compensate for that. But you should be able to stay within the normal range. So just because I ate an entire bag of chips one night because I was bored, not that I would do that, but just because you do that, it doesn't mean your body's going to go completely out of whack, right? Anyway, and so we're going to talk a lot about how we maintain this with negative feedback loops. And when I say negative feedback loops, anyone know what I mean by that? Perfect. We will learn all about it right now then. And again, don't feel bad. You can be wrong. It's okay if you answer something and it's like, well, it's not quite it, because it's really important, because if you have an incomplete understanding of something, guess what? There's probably at least 62 other people that may have that same misunderstanding. So don't feel bad about being wrong. I will never penalize anyone or make anyone feel bad for being wrong, or at least that's my intent, to never make anyone feel bad about that. That's okay. We can have a conversation about it, though, and then we'll try to help reinforce everyone's understanding. Anywho, negative feedback loops are going to be achieved by three main things. You're going to have some sort of sensor, which are going to be able to detect when something is in the normal range or when it kind of goes out of whack, right? So we have sensors that can detect things like blood pressure. We have sensors that can detect things like serum osmolarity. Anyone familiar with osmolarity? What is that? Yeah, it's like how much stuff is in the blood, essentially, right? So it's like how much solute is in the blood. We'll cover these concepts again, but basically there's a certain osmolarity you want to stay within. If you go outside of that, we have sensors that can pick up on that and detect, hey, the blood's too concentrated, or hey, the blood's too dilute. We have sensors for everything, right? And then there will be some sort of integration center. Usually it's going to be things like the thalamus or hypothalamus will be able to take that information and say, hey, this is out of whack. We need to do something about this. And that will begin this cascade that will trigger an effector. An effector is going to be whatever is going to trigger the opposite effect of what has happened. So for instance, if the blood is too concentrated, you're going to have an opposite effect that occurs with this effector that will help to dilute the blood out, right? Because again, you want to maintain that normal serum osmolarity. Or with pH, if the pH gets too high, there will be an effector that will help to bring that pH back down within the normal range, okay? Again, just some examples of, say, for instance, we have a normal range here. You can see as time goes on this x-axis here, as the value, whatever happens to be, goes up, you're going to be able to trigger that sensor. It's going to go to the integration center, and then it's going to cause an effector to be activated, and this will bring it back down to the normal range. And that can happen in both directions, right? Because again, serum sodium 135 to 145, you can go above that and you can go below that. So you need to be able to activate different effectors to be able to bring that into the right range again. Okay. We'll talk about more specific examples going forward as well. So one good example here would be the hypothalamic thyroid axis, right? So the hypothalamus, the thyroid, we're going to see that this is a very important axis because all sorts of disease states can occur when this goes out of whack. You have a patient who comes in and they're, having some weight gain and they're having a lot of fatigue and not feeling well and they're kind of cold all the time. This can be indicative of something where this homeostasis has been lost and you have a patient who's hypothyroid, right? There's lots of reasons for that, but this is the normal mechanism to help kind of prevent that. So again, looking at your axis here, we have the hypothalamus, which is located where? The brain, right? We have the anterior pituitary, which is located right below the hypothalamus in the brain as well. You're going to see this is really important for the endocrine function. We're going to see there's lots of hormones that get secreted from here. And then this is going to communicate with the thyroid, which is where? Right here, right? So basically, you're going to find that normally, in normal function, in order to stimulate the anterior pituitary, we're going to have a hormone called thyrotropin releasing hormone, or TRH. That will then be released, and that will trigger the anterior pituitary to release something called thyrotropin, or TSH is another name for that, thyrotropin stimulating hormone. Once that gets secreted, this will then have a positive effect on the thyroid, and that will stimulate to secrete thyroxine. Thyroxine is our normal thyroid hormone that floats around in the blood and causes all the normal effects that thyroxine does, and we'll cover those later on in the endocrine section. Now, normally, when the body is detecting there's enough thyroxine around, T4 is another name for this, you'll induce a negative feedback loop. Because again, you don't want this to happen ad nauseum because basically you'd end up having too much thyroxine around, and then that would develop into what? Hyperthyroidism, absolutely right. So we'd have too much thyroid hormone around, that cause hyperthyroidism. We don't want that. We want to keep that thyroid hormone within the normal range. So you have a negative feedback loop that will feed back, again here, and will shut down the anterior pituitary. Once the body senses there's enough of that around, well, hey, let's go ahead and shut this down. We don't need to produce anymore, right? You'll also find some negative feedback loops that will also feed back into the hypothalamus as well. It's another place that can happen. But basically, you need to maintain this negative feedback loop because if you don't, if you lose this, then you're going to find you have way too much thyroxine around. You can have what we call thyrotoxicosis, which is a form of hyperthyroidism. You can have thyroid storm, which is a very severe form that you get very hypertensive and very hyperthermic and all these things. Again, if I say a term you don't understand, just give me a heads up, right? I want to make sure everyone understands what we're talking about here. So anyway, so these negative feedback loops are super important. If you miss this, and then that's where a disease can happen, right? So a good example of this would be when you develop a goiter. What's a goiter? Yeah, an enlarged thyroid gland. So essentially, and you can kind of see this picture of this guy here. He's got his big lump here on his neck. This is what could happen if you were to have this negative feedback loop kind of be interrupted here. So for instance, normally at the hypothalamus, releasing that TRH onto the anterior pituitary, releases TSH to produce thyroxine. Now, one of the necessary components of thyroxine is actually iodine. So if you don't have enough iodine around, it doesn't matter how much TSH your anterior pituitary is secreting, you can't produce any more thyroxine. You're just missing that factor there, right? So you can have as much as you want, but you're basically never producing that T4, and that negative feedback loop never gets activated, okay? So I'm missing that T4, never shuts off the anterior pituitary, never shuts off the hypothalamus. What do you think it's going to do to the thyroid? It's going to overstimulate, right? Because I'm going to have way too much TSH. It's going to overstimulate this. And again, here's what happens when it kind of goes awry when you have inadequate iodine intake. You have low T3, T4, no negative feedback loop gets activated here, and thus the anterior pituitary puts out excess TSH. TSH stimulates the thyroid, and that causes, what do you call it when something gets bigger? Yeah, megaly would be a good one. Hypertrophy, though, is kind of the term I'm looking for here. And again, hypertrophy would be when you have the kind of the expansion of the cellular tissue gets bigger, just like you have muscle hypertrophy when you work out. Same thing happens here. You have this stimulus, this TSH that is in excess and causes that thyroid to grow because, again, it wants to make T4, but there's no iodine there for that to occur, right? So you see this a lot in like impoverished countries where they may not have iodine enriched foods, things like that. You can have these kids that have these giant goiters because they just don't have any iodine to produce that T4, right? And again, the important thing here is to get the concept. When we talk about the thyroid later on, that'll be important to memorize those kind of individual features, but this is mainly just to illustrate the process here and how disease can occur once those negative feedback loops get lost and homeostasis is not in balance. Okay. Some other ones, so for instance, temperature is another big one we see negative feedback loops for. So for instance, if your body temperature becomes elevated, how does your body respond to that? You sweat, right? So, and again, a good example of this would be last year when I was teaching this class. The ACs were all going out on us, and so it was the dead of summer, and we had a very hot classroom, especially up here. I get really hot even if the AC is working. But the body's going to respond to that because it wants to drop down the temperature, and so it's going to cause us to do things like sweat. How does sweat cause us to cool down? Yeah, so we call it evaporative cooling, and that's actually an important concept we'll talk about when we talk about like drugs that cause hyperthermia or different disease states that can do that. But right, so you cause your sweating to occur. You also cause blood vessels to dilate because that helps to bring that heat up to the skin to where it can release some of that heat. And so again, and that will help to bring the temperature back down, and that will get you back into homeostasis, right? On the other hand, though, if you had say the temperature is too low, what does your body do to respond to that? Shivering, right? So again, very different physiologic processes are occurring here, but both have the same function to try to get your temperature back into the normal range there, right? In some cases, you want to cool your patient down, right? So anyone ever heard of therapeutic hypothermia? Where do we see that being used? Yeah, absolutely. So after a code, you have someone who has cardiac arrest, like a VFib cardiac arrest or something. We do a therapeutic hyperthermia. We'll chill the patient down because we know that we cool them down. Helps to kind of preserve that tissue. Helps we see increased, trying to think of the word, better outcomes when you cool these patients down for a prolonged period of time. But the patient, when you cool them down, what are they going to try to do? Start to shiver, right? So again, because the body does not like that temperature being brought down low, even though we're doing it for their own benefit. They're trying to bring the temperature down low, and so they start to shiver, and that helps to bring the temperature back up. We don't want that. So we'll do things like giving them a paralytic. We'll give them something that paralyzes them to prevent their skeletal muscle from shivering. And that's how we keep those patients cool, right? So little things like that where, again, knowing how the normal physiology is working, we understand why we're doing certain interventions or why we're using certain medications and things like that, right? So okay, so again, normally we have these antagonistic effects, and that's what helps us to maintain homeostasis, right? So again, when I mentioned, having shivering is an antagonistic effect to having hypothermia, right? The sweating is an antagonistic effect to having hyperthermia in those cases there. Again, things that help to maintain these conditions within that normal range called dynamic constancy. And so other things we can see this with would be things like blood glucose. We mentioned you have things like blood pressure, you have things like blood pH. All these different things are going to have an antagonistic effect. It's going to help to bring things back into line, right? So think antagonist, think like a little brother, kind of like punching you or something, right? He's an antagonistic. These are going to be things that try to get you back into homeostasis. Okay. So again, normal set point here, if you're looking at, say, a pH of the blood or something like that, again, you're going to have variation there. And it's important to have these antagonistic effects intact in order to make sure you stay within that appropriate range there. So for instance, if you're looking at temperature, you get too cold, you shiver, brings temperature back up, and then you can start to sweat again, right? Being here in Florida, guess what we do a lot of? We're going to be doing a lot of sweating. That's okay. You don't have to worry about shivering too much here, especially down in landlocked Orlando. Anyway, another really good example of this, and this will come back up again and again, is going to be regulation of blood glucose, right? So what happens if you have low blood glucose? Okay, so yeah, so that we'll talk about that. That's a compensatory effect. That's one of those things we're going to do to help relieve that blood pressure, or that blood glucose. But what happens when you get hypoglycemic? Like, you're hungry, right? You hangry is what I like to determine. Anyone ever been hangry before? The majority of you probably been hangry, but that's what you get basically. You get you get kind of tremulous. You get very irritable. You can eventually, if you get too low, you can see things like syncope, right? Because again, the brain needs that sugar in order to keep functioning. But basically, we have a lot of compensatory mechanisms to keep blood sugar under strict control, because again, if you go too low, that's obviously going to be very detrimental. It can be life-threatening. If you go too high, that can also be a problem. Usually not as severe of a problem, at least in the short term, but it is one of those things you really want to keep in control. Because if you have too high a blood sugar, normally that manifests as what disease? Yeah, diabetes, right? So we'll talk about the difference between diabetes type 1 and type 2, but basically know that that's usually what you find when you have people who have kind of chronically high blood sugars. So anyway, so what is this compensatory mechanism that happens here? So normally the two big sites you're going to see that help to regulate blood sugar are going to be the liver and also the pancreas. Now, pancreas is going to be really important because it helps to secrete several hormones, things like glucagon and things like insulin, right? Those are the two primary things that help to regulate our blood sugar. Now, insulin, what do you think insulin does to blood sugar? Should decrease it. Yeah, so it should decrease it. You're going to find that when you have, say, too high of a blood sugar, and when might you, as normal, healthy individuals, develop high blood sugar? Yeah, eating, right? So after you eat a big meal, say, for instance, you ate that entire bag of chips, your blood sugar is probably going to rise pretty significantly. So we're going to see that insulin is going to respond to that. It's going to say, hey, blood sugar is too high. Let's go ahead and secrete some insulin from the pancreas. There's beta cells there. And that's going to help to do things like drive blood sugar into the tissues, right? It's going to drive it into the muscles, it's going to drive it into adipose tissue, into the liver as well, and that will stimulate what we call glycogen formation. Anyone heard of glycogen before? Glycogen is a storage space for sugar. We'll talk about that later when we get to cellular respiration, but just know that's where we kind of store it up. And so normally we have glycogen that gets stored when you're in a high glucose state, because again, we have sugar there in the blood. We don't need to, it's right there ready for use. We don't need that glycogen to be broken down. However, on the other hand, say you get too low of blood sugar, we need to be able to compensate for that as well. And that's when the pancreas is going to release glucagon. Anyone heard of glucagon before? Usually you'll see like diabetic patients will give glucagon to them as a prescription because we want to make sure that they can help regulate their blood sugar. But basically, the glucagon will be released in response to low blood sugar, and that's going to stimulate the liver to break down glycogen. And we know what that process is called when you're making glucose from the liver? Gluconeogenesis, right? So you have gluconeogenesis occurs, you have glycogenolysis because you're breaking down, you're lysing glycogen and producing new sugar. So again, the liver is very important here, and it needs to be able to respond to those hormonal responses there. So insulin will cause glycogen to be formed. Glucagon is going to cause glycogen to be broken down and get formed into glucose, and then the liver can release into the bloodstream, and there you go. Now you've raised your blood sugar back up to hopefully a normal range there. All right. So again, these are antagonist effects. Glucagon, insulin, very much antagonistic to one another. But important we have both of those in check, because otherwise you can have hyperglycemia. We don't want that to occur. Right. Everyone with me so far? Any questions so far? Again, I do speak a little fast. I understand that if you need me to slow it down somewhat. I just had a big coffee, so let me know. Otherwise, the video, you can always slow that down. Some people like to speed me up on the video, so who knows? Anyway. Again, just kind of another picture here showing the sort of seesaw sort of effect here of looking at your, for instance, here we're looking at blood sugar. Again, you have to maintain a delicate balance there. If you tip one side over too far, you can find that you run out, you get outside of homeostasis, and you're going to find that this is where disease occurs here, right? So kind of think about someone who's really screwed up the seesaw there. That can occur in our patients, right? You can kind of equate that back to someone who, for instance, say they don't produce any insulin themselves, right? Anyone know what type of patient might not produce insulin? Type 1 diabetic, right? So we'll learn more about that. But basically, type 1 diabetics cannot produce their own insulin, and so because of that, guess what their blood sugars are going to do? They're going to go up, right? Because they don't have any insulin. They've tipped that seesaw way too far on the one end into where they're not producing any insulin, the blood sugar is too high, and we have to help them by giving them exogenous insulin, right? When I say exogenous, I mean from the outside, we're giving it to them, versus endogenous would be what a normal patient would be able to release on their own from the pancreas, right? So again, we want to make sure we're keeping the seesaw right at that balance, otherwise we're going to see disease develop there. Okay. Now, on the other hand, you could also have someone who has like an insulinoma, or someone who has a tumor that actually secretes insulin, in which case, what do you think their blood sugar would do? Yeah, it'd be very low, right? Because again, they're releasing too much insulin. Their glucagon would be trying to help to regulate that, but again, there's only going to be so much it can do within a narrow range there. So now there's not just negative feedback loops. There's also what we call positive feedback loop. This is going to be something that helps to stimulate a process to, it's going to kind of amplify the process. It's going to make it more stronger signal for whatever physiologic process is happening here. So again, good examples of this would be if you clot or if you have a blood vessel that you cut, right? You get a paper cut or you have a laceration or something, you're going to bleed. Do you want to bleed indefinitely? No, you typically want to stop that, right? And so this is going to be done through a positive feedback loop. We're going to look at an example of that. We're going to see things like uterine contractions, which, my wife just did 5 months ago, right? We're talking about oxytocin, how that's important for that. I overshare. Don't tell my wife. She doesn't watch these videos, fortunately, but so I do overshare a bit. Take it as you may. And then we'll also talk about luteinizing hormone, very important for ovulation. So I'll show you those examples here coming up. So anyone ever seen this clotting cascade before? Anyone ever memorized it before? Hopefully you have those memories intact, because you will need to learn this again. This is a very important clotting cascade here, but basically what we're going to learn in other courses that you need to have different factors present within the blood. And the nice thing about this is it has this kind of cascade sort of effect, it has this amplification, because we want a positive feedback loop, because when we have damage to that vessel, we want to clot that thing off very quickly. However, do you want to clot off indefinitely? No, because that can cause thrombosis, right? You can see emboli form because of that when those clots break off. We don't want that to occur, right? So it needs to be kept in a strict sort of balance here, but it's important for that really acute sort of phase there when you have that injury. We need to clot that off quickly, and that's where these positive feedback loops can be very useful. So for example, say for instance you have damage done to the vessels here, you're going to have activation of different clotting factors, and again for this purpose right now, don't memorize this. We'll talk about hemostasis later on. That's when we're going to need to know those factors. But we're going to have, you see that factor 12 activates factor 11. Factor 11 activates factor 9. Factor 9 activates factor 10. And then 10 will then activate factor 2, okay? Notice here that 2 can then feed back and actually start to activate these factors again, right? So again, by making factor 2, I'm going to be strengthening that cascade again because it's going to feed back and actually cause this to clot off even more, okay? That's a very important process there because again, when you want to clot quickly, but then we're going to see that there's also natural anticoagulants that would be very useful to prevent that process from kind of going haywire. So again, it has to be a delicate balance, but this is an example of a positive feedback loop. Once you have that fibrin being formed here, this is what kind of solidifies that clot, and then you stop bleeding, right? Which is what the main intention there is. Kind of makes sense? Again, you're going to find patients that are missing some of these factors here. So if they were missing one of these factors, what do you think would happen? Yeah, they can't form clots very well, and then they bleed, right? So for instance, if you're missing factor 8, if you're missing factor 8, that's a type of hemophilia, right? So again, that's one of those things where we have kids come into the peds ER all the time because they had an injury, say they were roughhousing, as kids do, and they bump their heads or something. Like, we have to make sure that we give them exogenous factor 8 because otherwise they're not going to be able to activate this positive feedback loop. They're not going to clot very well, and then they can have an injury, right? So they can have something like subdural bleeds. They can have all sorts of different issues that come about from missing those factors. On the other hand, you have patients who are missing some of the antagonistic factors here, and they can actually be more prone to clot. Again, we'll talk about that a little bit later. Just know this is an example of a positive feedback loop. Another one would be here, the positive feedback loop that is stimulated by labor, right? So again, if you have a baby who's ready to pop out, ready to explode on the world and keep their parents up through all hours of the night, basically what you're going to end up finding is that as the head starts to push down on the cervix, that's going to be sending signals back up into the brain. And you're going to find that this actually stimulates a hormone called oxytocin. You ever heard of oxytocin before? Kind of called like the love hormones, kind of like what helps to solidify that bond between like baby and mom. And so that's one of those things where oxytocin gets stimulated. It's going to help to stimulate contractions of the uterus. So you're going to have, again, the bloodstream is going to carry the oxytocin, get transported back to the uterus, and that stimulates uterine contractions to strengthen, right? Because again, when you want that baby to come out, you need to get that baby out, right? And so oxytocin really helps to stimulate that. So again, you're then squeezing that baby down even further, it puts more pressure on the cervix, that feeds back up into the brain, and then more oxytocin comes out, right? So again, this helps to amplify that signal, to push that baby out, and then once it's gone, then you're done, right? You don't have to continue with that oxytocin. And even in some cases, we'll actually give women exogenous oxytocin to help kind of stimulate that process as well. So if anyone's ever been there in the labor process, God help you, but may see people being given oxytocin because that actually helps to stimulate that process even further if their positive feedback loop isn't strong enough on its own. Here's another example of where we're actually having hormones FSH and LH. LH stands for luteinizing hormone. FSH stands for follicle stimulating hormone. These are very important hormones for stimulating the ovulation process and kind of kicking off the menstrual cycle. Again, guys, don't worry if you don't have an inherent understanding of the menstrual cycle. I didn't either for a long time. In fact, I still don't understand how women work quite well. But we'll talk about this in the reproductive section later on. Just know, again, this is an example of a positive feedback loop. So normally you're going to have things like FSH. And again, this graph is really nice because it kind of shows you where different hormones are kind of surging and peaking at different points in the process. So again, usually menstrual cycle lasts how long? 28 days typically, right? And so say starting down with day 0 here, going up to day 28, you're going to see that the hormones don't stay static throughout the whole process here. They definitely have different variations during different parts of the month. So for instance, you have FSH that is being released early on, and that is coming from the anterior pituitary. That will help to stimulate one of these follicles to develop and eventually develop into an ova that can be implanted with, right, or the sperm. And so that FSH will be stimulated initially, and then eventually you're going to have this estrogen start to surge up because you actually find this this follicle actually helps to stimulate estrogen production down there. And then eventually what you're going to have is a surge of LH. Surge of LH is what's going to cause the basically the egg to kind of release off, and then this will help this is the ovulation process there, right? That's when women are going to be most fertile, is when that ovulation process is happening. That's due to LH, right? Because again, it's surging up, and then once it's not needed, say for instance, say the egg is never implanted, then we don't really need all that uterine tissue anymore, and then we'll have progesterone kind of come in and kick all that stuff out, right? And that's when you actually have the menstrual bleeding that occurs there, right? So again, we'll get more into detail on this later on. Just know LH is one of those examples of a positive feedback loop. Normally, you would expect that by having high levels of LH, that would feed back and shut down its production, but in this case, it'll have a a predetermined surge period, usually late, during that second week of the cycle, and then it'll go back down to normal levels, right? Okay. All right, so it's good to know, when we're dealing with a patient, say anyone who's working in the ER, anywhere in the medical field, normally if a patient comes in with a complaint, what's one of the things that you do to them, right? So you get their history and all that good stuff, but what's one of the next steps you take? Vitals are good, right? Vitals can be very useful. It tells us, what the blood pressure is doing, temperature, all that good. What else can you do? You may want to get some blood from them to do labs, absolutely. So you want to do labs, and so again, we can check on a lot of these different features here by using laboratory values. And again, every lab you go to is going to be a little different. You're going to find that different normal ranges will vary based on which lab you're dealing with. So for instance, you may see one lab that has serum sodium a normal of 135 to 145. Some places may be 137 to 147. It just depends on the lab you're dealing with and their equipment. So get used to that. However, we'll deal with certain normal ranges here. But by knowing what the normal ranges should be and seeing where your patient's at, whether they're too low or too high, that can help you aid in your diagnosis, right? So for instance, if I had a patient comes in with a big fat goiter, I'm going to go ahead and test them for their TSH levels. And I'm also going to test them for their T4 levels, right? And so for instance, if I come back and they have a low T4, but they have very high TSH, that aids in my diagnosis of hypothyroid, and that's why they have that goiter, because that TSH is such high levels. We'll go into more detail on that, but labs are very, very useful from this standpoint. We also do things like assessing for the effects of drugs and other interventions, and can give us a large amount of information. It can also give you a lot of misinformation, as we'll see going forward. So you don't want to just get every single lab known to man for your patient. Why don't you want to do that? It's expensive, right? And it doesn't always give us a lot of useful information. So it's important to know and be very judicious in which labs you're going to be ordering for your patient. Anyway, just some examples of different things we'll have normal ranges for. And again, don't memorize this list. It's just to really kind of illustrate to you different labs you may be getting in your patients, different things we can use to help us aid in our diagnosis here, right? I always hear like a lot of typing whenever I say, don't memorize this. But anyway, all these are super important because we need to be able to assess these in our patients and figure out what's going on. So for instance, if they're coming in complaining of lethargy and say they're just coming in complaining of fatigue, there's a gazillion different things that can cause fatigue, right? But by using the judicious use of labs, I can kind of tell, okay, is it because of hyponatremia, are they hypoglycemic, or are they hypothyroid? Different things you want to be assessing for when you're working with these patients for a specific complaint, right? Okay. So basically when you're regulating body function, there's two kind of main ways to do this. There's kind of a really fast way and there's a little bit more of a slow way. And so the first one's going to be this nervous system innervation. So you guys are familiar with the autonomic nervous system, right? Are we under control of the autonomic nervous system? Not really, right? And so autonomic gets broken down into what two main types? Parasympathetic and sympathetic, right? Which one is your fight or flight? Sympathetic. And of course, don't read the slides before I'm asking questions. I usually give away my answers right there. Right, so if, say, for instance, you were down eating your lunch, as you may do today, and an alligator popped out of the lake. I don't actually know there's alligators down there, but say, for instance, there was an alligator, he popped out. Which nervous system do you think you'd be activating? Hopefully your fight or flight, right? Hopefully you're not a crazy person when you've had an alligator. Your fight or flight usually will end up getting activated. It's a sympathetic nervous system. On the other hand, you also have your parasympathetic, which is going to be better for what? Rest and digest, right? So that's the way a lot of people normally think about it. Parasympathetic is going to be good for, say, for instance, the alligator did not jump out at you, but you were eating your lunch and then you had that nice rest and digest, that parasympathetic outflow happening there to help you digesting food and helping to regulate a lot of that. We're going to talk about those a lot, especially later on in the course here. These are absolutely paramount to understand when these get activated, when they get inhibited, because that'll also inform us when we're using a lot of medications, especially like cardiovascular medications. This is super imperative to understand. So we'll talk more about those in detail later on. But that's a very fast way of changing things. So for instance, that alligator hops out. What do you think are some physiologic changes that are going to happen? Heart rate increases. Do you think, is it like a slow process take minutes to happen? No, you're going to be heart's pounding on your chest immediately, right? Or if I call on one of you guys by name, I don't have the list up here, so I can't do that right now. But if I call on you by name, chances are you'd have that direct innervation of that sympathetic nervous system. Your heart's going to start to pound, right? What else might happen? Respiration might go up. Vasodilation, right? So again, you're going to, to certain areas, right? So you're going to see that typically blood pressure is going to go up, typically, right? Because you want to help to force blood to the right areas where it needs to be. But some areas will be vasodilating, some areas will be vasoconstricting. Again, we'll get into more detail on that later, but yes. What do you think your pupils do? They dilate, right? Can you ever like see, anyone ever watched Requiem for a Dream? You see those scenes where they like do drugs and all of a sudden like their pupils are changed. It's not always accurate there, but mydriasis, right? That pupil dilation, that's a big thing that happens during the sympathetic activation of the nervous system there, right? So again, fight or flight, because you want to take in as much light as you can to see the dangers there, or see the alligator coming at you. So that's very quick, right? It happens almost immediately. Versus the endocrine system, which is going to be better for long-term sustained regulation of these systems here, right? So again, not as fast. Hormones don't work nearly as fast as the nervous system does. However, very important for more long-term control. You can have both of these interacting together, right? You can have hormonal control along with neuro control for various things here. So for instance, imagine we have a patient who's lying down, right? And all of a sudden they're going to stand up. So what do you think that does to your blood pressure? It typically is going to drop. What do we call that? Orthostatic hypotension, right? Because again, one of the things I always harp on is primarily where is your body concerned with sending blood to? The heart and the brain, right? So your body always wants to make sure that your blood is at least going to the heart and the brain, because if you lose those two, guess what? You don't have much left, right? So I can lose a leg, can't really lose my heart so well, right? Or my brain. Kind of need a brain. Some people say I don't have a brain, but I do, I think. So anyway, they stand up, blood pressure falls, and that's going to be that stimulus, right? So we're going to have certain sensors that are going to pick up that blood pressure drops. And so those are called baroreceptors. We talk about those BARO receptors, and they'll detect that the blood pressure is too low. And so the brain's going to say, hey, wait a sec, we need to increase this pressure here. And so again, there can be ways that we can do this either hormonally or ways we can do this with direct neuronal innervation. So one of the things we can do here is that we're going to find that with the sympathetic nervous system, which is going to be really good for increasing blood pressure, that will be stimulated in the brain, and that will be releasing its effectors, right? So we'll talk about the neurotransmitters that work on that, but that will stimulate heart rate, right? It'll stimulate cardiac output to help increase our blood pressure back up to normal, right? So that way, when you stand up, you don't get super dizzy. You may have a moment of it, but as the heart responds to that by increasing cardiac output, you kind of get back to normal, right? Now, keep in mind, patients tend to lose the ability to do this quite as well as they get older, right? So for instance, we have an older patient, say someone who's like 80 years old, they stand up from lying down position, guess what? Their heart has a harder time responding to that, and that's when you see a lot of like dizziness, you see a lot of syncopal episodes. They fall, and when old people fall, what do they typically do? They break a hip or they break a bone, and that's usually super debilitating for them for the rest of the remainder of their lives, right? So this is one of those things where you want to prevent falls for your patients. It's a big thing, especially in the hospital setting. You'll have patients that are fall risk. You need to be wary of them, because if they fall and break something, it's usually not a good thing for your patient. So anyway, so again, by having that direct innervation, that will raise blood pressure up, get things back to normal, and then at that point, you can kind of, once blood pressure is regulated, then you can decrease that sympathetic outflow, right? Make sense? Anyone know what neurotransmitters the sympathetic nervous system uses? Norepinephrine, yeah. So we'll talk a lot about neurotransmitters. Again, I'm kind of a nerd for that sort of stuff, so we'll talk about those in detail later on. So you can also have different effectors as well. So for endocrine control, you can also have different hormones that can help to regulate this. So for instance, cortisol, which is going to be our main stress sort of hormone, can also do things like help to raise blood pressure, but it's a lot slower sort of process. It takes hours in some cases, but it's going to be better for long-term control, right? So again, people are chronically stressed out, like you guys might be for the next 2 years. What do you think your blood pressure is going to be? Higher or lower than when you started school? Higher, right? So again, for instance, when I start class this morning at 8 o'clock, you probably had direct innervation that raised your blood pressure immediately, right? Or right before test time. However, you're going to be kind of chronically stressed over the next 2 years, and you'll probably have a lot more cortisol being produced, and that's going to kind of raise your blood pressure for the long term, right? Because you can wear out your sympathetic nervous system over time. It's better for kind of quick bursts, but that cortisol is good for the long haul, right? And again, I always wish I could do like a preset of labs for you guys before you start school, like right in the middle, winter semester, and then on rotations. It'd be interesting study to see, but not super ethical. Talk about ethics and studies later on in EpiBio. Anywho, but again, these are very important signals here, right? So again, it's important to understand we have both neuro and endocrine control. Both of these can be going wrong in your patient. It's important to diagnose which one is which in order to have a treatment that's going to be effective. Okay, so any questions from the first half? Fantastic. Yeah, one of the second years just reminded me, as long as no one needs the automatic defibrillator today, we'll be doing better than their first day, so that'll be a good thing. It was fine. They did fine. We had to get it at least, but that's why we have another one here on the 3rd floor now. So just in case any students fall out, we have the ability to handle that. Honestly, you're more likely for one of the faculty to drop dead than you guys. You guys are mostly healthy, but you just never know. So anyway, I know babies being born. We had someone who had a baby born the first day too. Not in class. It was someone else. Their wife was at the hospital, I think. Anyway, okay, so continuing on, we've never delivered a baby in class to my knowledge. That would be highly irregular. You guys are not qualified for that sort of thing yet. Well, maybe some of you might be EMTs. I don't know. Hey, oh yeah, it's a good breakdown. So any EMT/paramedics? Oh, you got a few RTs. Let's see what else. Nurses. Any pharmacists? Oh, you're okay. Any pharmacists? Oh, you guys would have done very well in pharm if that had been the case. I had one people on rotations as a pharmacist before him, but no physicians, I imagine. Okay. You never know. Some people, they worked in another country. They might actually come here, and this is a quicker way for them to become practicing again, rather than to go through residency potentially. But anyway, any other things that I missed? A lot of scribes and a lot of medical assistants. Dietitian, cool. That'll be very useful later on. You can teach me and us a lot of stuff, I'm sure. Anyone else? Okay, cardiac monitor tech. Okay, very cool. Yes, sir. Surgical tech, very cool. Yeah, so I like to bring in other people's perspectives as well, because guess what? I never have worked directly in surgery. I work a lot with surgeons and anesthesiology, and I work a lot, I work with people in the cardiac realm, but I don't do that work specifically. So it's really good to get you guys' perspective on things. Feel free to share. If you have an example, like, hey, I saw this patient that did this thing that is similar to what you're talking about, or it happened totally different from what you're talking about. That's a great discussion point. Can help to really solidify some of these concepts for you. So if you have anything, bring it up. If you've seen something weird. Anywho, so again, hormonal control for a lot of these things I mentioned is a little bit slower, better for long-standing control of these things. However, some of them can work kind of fast. So for instance, with blood sugar, insulin can be released pretty instantly in response to high glucose, and that can help to bring that back down into normal control, right? So that would be an example of hormonal control. Again, it's not through direct innervation of the organs. It's going to be actually through secretion of these products that will circulate around the blood and be able to affect multiple different types of tissues, right? So again, that's really the big difference between kind of that direct innervation, why it's so fast, versus something like hormonal control. Okay, and again, normally negative feedback loops have to have an antagonist, or most often will have an antagonist that will help to combat the effects in order to help make sure we don't kind of go too far in the other direction. So for instance, the antagonist to insulin would be glucagon, as we mentioned, right? So that's kind of the kind of prototypical example of that. There's many other ones that are out there. So for instance, if you're thinking like from the neuro standpoint, if you think about someone like an epilepsy disorder or seizure disorder, there's GABA, is a neurotransmitter that inhibits the brain. We have glutamate that stimulates the brain, right? Those are antagonistic to one another, but they help to regulate things. If you go too far in either direction, bad stuff happens, right? That's when you get disease that occurs there. So, again, we kind of covered this already, but just know that these negative feedback loops can happen in the opposite directions of one another to help regulate. Make sure we don't get hypoglycemic. Make sure we don't get hyperglycemic in these cases here. And again, normally when you have someone who, say for instance, is fasting, say for instance their blood glucose drops down. So say someone started a brand new keto diet, had no carbohydrates, and they just spent the whole weekend eating a ton of carbs. Their blood sugar is probably going to drop, right? And so your pancreas is going to respond to that, typically by decreasing insulin release, right? Because you don't want any more insulin because the blood sugar is already too low. So that will have effectors that will shut that down, and then you'll have glucagon be released as a response to that, right? And that will help to stimulate the liver, release glucose, and all that good stuff, right? Just know that there's lots of different effects that can happen here. Usually when you're kind of increasing the effect of one, you're kind of decreasing the effect of the other, because again, you want to make sure you maintain that seesaw balance there to get the glucose back under control here as it happens. And in some cases, you may actually run into issues where you'll find that these normal levels of different hormones will actually be out of whack in cases of disease. So again, homeostasis, you have normal levels for typical patients, but as disease progresses and is more long-standing, you'll find these normal set points will tend to drift. So for instance, when you have someone who has blood pressure issues, normal blood pressure we said was 120/80. For some people, when they're chronic hypertension, say 150/100, maybe they're new normal. And if you deviate from that, that could be hypotensive to them because their body is so used to having that new blood pressure. Or so for instance, someone who has blood sugar that rides high normally, having a blood sugar, say like a normal like 100 or so, let's say 100 is normal blood sugar, they may sit at 200, 300 chronically, and that's kind of their new normal set point. So just know this can drift in cases of disease, and it's important to take that into consideration there, right? Okay, so that's it for kind of negative feedback loops, maintaining homeostasis. Now I get into the actual body function. We'll talk about different types of tissues that we're going to encounter. These are going to be just the basics about these tissues to kind of get us all up to speed here. So first off, with muscle tissue, there's three main varieties here. So skeletal muscle, which normally you find where? Around the skeleton typically, right? Cardiac muscle you might find in the heart, right? Some of these things are pretty obvious. So if I'm asking questions, I'm not trying to trick you guys ever. Sometimes I try to trick you, but just in class, not on the test. And then smooth muscle, where would you find smooth muscle? GI tract's a good one. Where else? Blood vessels. Again, they can help to regulate constriction or dilation of the blood vessels. Anywhere else? Talk about the eyes. Lots of different places where we're going to have smooth muscle working there. So again, the first one we'll talk about is the skeletal muscle. Typically is going to be under a lot of voluntary control here. So for instance, when we say voluntary control, that means what? I think about it, I make it happen, right? So again, I send a signal down from my brain saying, hey, I want to raise my arm up, and that happens, right? Usually you're going to find that most of these are going to be associated to bones via tendons, typically, right? So here's something like tendinitis, usually because they're straining that relationship between the muscle and the bone there. And normally when they contract, that muscle contracts, that's when you're going to see movement of the bone there, is via those tendons that happen. You may find that some of these are not actually causing skeletal movement, but they're still under our voluntary control. I've been wagging mine for quite a while now, so you might use yours later, but the tongue is very important for that. So again, it's under conscious control. However, it's not really associated with any kind of bones or anything, not meant to move bones, essentially. Other ones, you might see some conscious control, but if you have things like the superior portion of the esophagus, it's important for swallowing. Make sure we're not having, product and different things going down the throat when we don't want it to. The anal sphincter, we'll talk about internal and external sphincter controls for different things like, urination and defecation, but also the diaphragm as well, right? The diaphragm used for what? For breathing, right? So again, we want that to be under conscious control to some degree, because again, we want to be able to control our breathing in some cases. Obviously there's some involuntary control that happens there when you're kind of thinking about it, because I'm not telling myself constantly to breathe in, breathe out, breathe in, breathe out, right? But I can control that when the need arises. Here's an example of what the muscle tissue actually looks like. Notice here, these are typically multinucleated cells. So I got multiple nucleus around here. Again, the nucleus does what for us? Stores all of our genetic information. We'll talk about the different cell organelles a little bit later on. But again, notice these muscle fibers here. Notice these are striated. Notice how they're going to be kind of running the length of the muscle. We're going to talk much more about function later on, and how that's actually going to be occurring from kind of the chemical basis. Cardiac muscle, on the other hand, is going to be a little different, and you'll notice some differences here. And again, we'll cover this more in detail when we get to actual talk about cardiac function. But notice here, these cardiac cells, these myocardial cells, are only found in the heart. And they have very specialized function. They're able to communicate with one another very well, and that is needed because when we have a contraction of the heart, you want it to happen in a very organized sort of fashion, right? So again, if your heart contracted all at the same time, would that be very effective at pumping blood to the body? Not typically, right? You want the atria to contract, that pushes blood to the ventricles. You want the ventricles to contract, that pushes blood out, right? That has to happen in a very coordinated sort of effort. If that doesn't happen, then blood doesn't flow well, right? And so this can happen with these things like these intercalated discs here. You notice these cells kind of communicate to one another. There's also a lot of these gap junctions that happen here. We'll go into more detail later, but just know that this is necessary. These cells are very specialized in order to allow the heart to function appropriately, as opposed to skeletal muscle. When I want to squeeze a skeletal muscle, guess what? It all squeezes together essentially, right? So we'll look at those differences there later on. Sodium and other electrolyte flow is super important for cardiac function, so keep those in mind. You have to have sodium in the right range, potassium in the right range in order to make sure the heart's working effectively. And that's really one of the big causes for arrhythmias. If you deal with a patient who's coming in who had an arrhythmia, had a cardiac arrest, it could be related to these electrolytes being out of balance here. We'll talk more in detail on those later. So again, just an example of some of these intercalated discs here that allow for these cells to communicate to one another. We're going to a specialized term for this called a functional syncytium. What that later on, but this allows the cardiac muscles to work very well together. And then we'll have our smooth muscle, and again, this is usually found around the walls of hollow organs. So again, you can find this in the digestive tract, which is very important there. Urinary tract, reproductive organs, blood vessels. This is another place where we can have a lot of medications that can affect this. So for instance, in the bronchioles of the lungs, anyone familiar with asthma, that's usually going to be a response where the bronchioles are going to be constricting, right? That smooth muscle constricts, and in response to that, I can give you something like an inhaler, like an albuterol, and it helps to relax that, right? So again, smooth muscle function is super important from a drug standpoint. We have a ton of drugs that can affect that smooth muscle there. Again, notice here this is not striated and it's going to be involuntary. So I can't will my my blood vessels to relax to drop my blood pressure. That's under all involuntary control. And here's another thing we're going to see a lot of both neuro control, right? Because the parasympathetic and sympathetic nervous system is important here, along with both hormonal control, right? So we're going to have different hormones that can affect that. Generally, you're going to find that these are going to be in layers that kind of run in different directions, right? So for instance, if you're looking at the stomach here, you notice here it has some longitudinal muscles that kind of run along the length of the stomach. You're going to have some oblique muscles that kind of run at an angle, or sorry, these are the oblique, and then we have some circular muscles that run around the organ. What do you think that the reason for that is? Yeah, so it can move in different directions, and why is that important in the stomach? Yeah, so we'll talk about peristalsis and how we transport things to the GI tract, but also the stomach's a big place where mixing happens, right? You release a lot of stomach acid, you want to mix that with your food, and you can do that by having those muscles all contract in different rates and at different times in order to mix that food, and then it can be expelled out into the small intestine, right? So again, here's an example of peristalsis. Again, this has to be very well coordinated, and we'll talk about the enteric nervous system a little bit later, but you have a very specialized nervous system that's just regulating digestion and regulating flow of contents through the GI tract. And so it's important that this be maintained very well because, again, if you don't have peristalsis, food's going to get stuck in places. You're going to have things not flowing very well, and that can cause all sorts of GI problems for your patients, right? So you can have things like, anyone ever heard of the term gastroparesis? What is that? Yes, you have delayed gastric emptying. Things are not moving out of the stomach, and so if you have a patient who throws up and they have like basically fully formed food, that could be a sign that things are not being peristalsis is not working effectively and things are not being moved out of the stomach, right? So again, you can do different kind of diagnoses based on the complaints, based on what's going on here, and kind of getting an idea of what's going wrong with the physiology under normal circumstance. But again, GI tract is probably the most common one you're going to think of, but it can also find this like moving urine from the ureter down to the urethra. It can be manifested or can be dealt with peristalsis in the same way. So again, it can be a very useful way to move things and fluids and stuff from one end to the other. It has to be coordinated. If not, then things get all screwy and things are going to get kind of held up in one place and then along the track. Okay, again, just an example of what the smooth muscle looks like. I'm not going to have any slides on the test. It'll ask you, like, which one is this? Is this cardiac tissue or is this smooth muscle tissue? Again, focus on the concepts here. That's the most important thing. Okay, so going from muscle, we have the nervous tissue here. And so typically you're going to find this in the CNS, which stands for central nervous system. And then we're going to have the PNS, which is peripheral nervous system. Just say peripheral nervous system. I had one student who kept saying PNS, PNS, PNS. And then for the autonomic, he say ANS, ANS, ANS. Just autonomic nervous system, peripheral nervous system. Just sometimes abbreviation can be not great for us. Anyway. Because they get confused and like, wait a second, I wasn't talking about reproductive organs. Yeah, anyway. Right, so typically the nervous system composed of the neurons and then also these neuroglia cells, right? Anyone know the difference between those two? So,
the electrical activity versus like protection of the brain itself.
Great, yeah. So the neurons are going to be the main thing. It's going to be transmitting these signals. We'll talk a lot about action potentials, and then the neuroglia cells are like the supporting actors, right? Those are going to be the guys who are going to help to do things like form the blood-brain barrier. Anyone ever heard of blood-brain barrier? Very important to help keep stuff out of the brain that we don't want to go in there. Usually the CNS is going to be a very protected sort of system where we don't want a lot of stuff, a lot of junk kind of getting up there, right? So we'll have all kinds of different cells that are going to help with that. Those are the neuroglia cells. We'll talk about those in detail in a minute here. So typically the neurons are going to be conducting impulses, and usually it's going to be a one-way conduction here, right? Typically, you're going to find they have three main sections. The first one being here is going to be the cell body, right? So this is going to be mainly where all the metabolism for the cell actually happens. Here's where the nucleus is where all the main functions are going to happen here. And you'll notice kind of coming off of here are the dendrites. What are the dendrites for? You know? Communication, right? Other neurons are going to be connecting to that, right? So again, this is basically the receiving end of the neurons where all these new signals are going to be coming in. Notice you have multiple dendrites coming off of one neuron. That's fine. You're going to notice that you're going to have one long axon. It's going to travel down, and then you're going to have these terminals here at the very end. And these are used for what? They communicate with the dendrites of another neuron, right? So again, or they could maybe directly innervate a tissue. So for instance, if this was, say, a sympathetic nerve that was releasing norepinephrine onto the heart, that could directly innervate that and cause heart rate to go up, right, as an example. So again, it could be to other neurons, could be the actual tissue, just depends on the type of neurons that you're dealing with there, okay? Again, signals only going to be going in this direction here. Only going to be flowing from the cell body because it's getting signals from the dendrites, it's going to be sending along to the terminals there, right? Other neuroglial cells, and again, when we get to the neuro section later on in the class, we'll go into more detail on this, but we have things like, say, like the oligodendrocytes, which are super important for helping with certain functions here. We're going to have things like the Schwann cells, which like things Schwann quite a bit. But all these are very important because if you start to lose these, then again, disease can happen here. So for instance, anyone know what these Schwann cells are doing? They help to form that myelin sheath, right? Anyone heard of the myelin sheath before? What does that do for our neurons? Kind of protects them, but also more importantly for action potentials. Goes faster, yeah. It helps to speed up conduction on these nerves very well. And if you lose that myelin coating on those neurons, anyone ever heard of multiple sclerosis? That's that disease state. You basically lose that myelin sheath, and then you have all kinds of neuro problems that show up in those patients, right? And again, MS patients can be very difficult to treat because again, they have so many different woes, and you're trying to figure out, okay, well, what's the actual issues here? How can I manage this? You know, what type of procedures should I do? Drugs should I do? But again, having that diagnosis, you can go back to the physiology and say, okay, I know what's wrong. Here's the pathophysiology now, right? So again, this directly informs what that pathophys is going to be. Just another slide kind of showing you what these are looking like. Again, notice how the supporting cells are going to be kind of helping out the function of the neuron itself. I'm going to say that again really quick because I screwed that up on the recording. Anyway, nodes are very important for helping the signal to go more quickly. It'll jump from node to node. The other thing I was going to mention here is going to be the synaptic clefts here. This is where the actual signal transduction is happening between different neurons. So if you had to think this is the terminal for one neuron, this is the dendrite for the next neuron. This is going to be the receiving end of that neuron there. And this is super important because this is where we have a lot of vesicles releasing different neurotransmitters, right? So this can release the neurotransmitter into the synaptic cleft here. This distance is very short, and that neurotransmitter can interact with the receptor. Once that receptor gets interacted with, then it can cause all sorts of different things down in different pathways down the road, right? So again, you can have different receptors for norepinephrine. Anyone heard of serotonin before? Serotonin is really important for this sort of thing, especially when you're talking about like patients who are depressed and have other kind of mental health issues. All this stuff is going to come back. So again, neurotransmitters are super important. We'll go into more detail on those later. But this is again where a lot of this business, this action is happening here between the terminal of one neuron to the dendrites of the next one. Again, that transmission is only going to be one direction. Okay. Next we'll have our epithelial tissue, and again, it's going to be helping to form not only things like our skin, but also going to be the lining for a lot of our organs, things like that for the GI tract. Lots of different types are going to be available here. We'll go into more detail on those as they get introduced with different organ systems. You're going to notice we're going to go kind of organ system to organ system as we go through the class down the road. Again, you can notice that usually the epithelial tissue type is going to be dictated by things like, the layers, the shape of the cells and things like that. And it's going to help to inform what their function is actually going to be. So for instance, when you have things like, the ciliated pseudostratified cells, that's going to be very useful for one sort of purpose in the body versus if you say, for instance, have, say one of these stratified columnar epithelium, right? And so again, depending on which tissue you're dealing with, you're going to have different kind of tissue organizations, and they're very specialized just for that function, right? Because again, skin cells are going to be better for protection versus your GI tract, which is meant for things like absorption, right? And you don't want to mix those two up. Okay. Other specialized cells can kind of be introduced and interspersed amongst these epithelial cells. So you have things like goblet cells that help to release mucus into the stomach. Why do you think that's important? So it can reduce friction for things trying to pass through the GI tract. The other big thing is helps to perform a nice protective barrier for the stomach, right? So again, when you're producing that acid, stomach acid, it can eat through pretty much anything, right? Eat through meat you're eating, things like that. We want to protect the stomach, make sure we don't auto-digest ourselves. And that's going to be a big thing you're going to find with patients who come in with like peptic ulcers, GERD, which stands for gastroesophageal reflux disease. You have lots of patients who are going to have manifest these issues, and things like issues with these cells can be really important here, right? And trying to diagnose your patient. Ciliated cells are also really important here as well, because what do you think cilia do? Yeah, so they help to aid absorption because the surface area gets huge when you have a lot of the cilia. What's the other big thing you might do? Kind of help flow things or kind of move things along. So the other big thing I think of ciliated cells, I think the lungs, right? The lungs are very important because normally the lungs, the base of the lungs, typically pretty sterile, right? There's really should be not a lot of bacteria down there because again, if you have bacteria causing an infection in the lungs, what do you call that? Pneumonia, right? So pneumonia is going to be when you have a bacterial infection there in the lungs, but normally we have these ciliated cells. They're going to be able to help kind of move all that kind of crud and mucus and stuff up into where we can just swallow it through the esophagus. And so if you have dysfunction of that, then you can have more likely to have pneumonias develop. So for instance, if you have someone who's like a chronic smoker, chronically inhaling all that really hot smoke into their lungs, they can kill off a lot of these ciliated cells, and that's where you're going to see that cells will try to respond to that kind of stress by changing themselves sometimes, right? So again, just like when you get scar tissue, or just like you develop a callus, same thing can happen like in the lungs. You lose those ciliated cells, and guess what? All of a sudden you have all this bacteria introduced in the lung, they're more likely to get pneumonias. Okay, so just an example how when the normal process goes awry, you can have disease develop. Okay. We also have our exocrine glands. These are going to be usually derived from epithelial tissues, and again, they're going to have special functions by secreting things through these ducts here, right? So, for instance, lacrimal glands. What do we use those for? For tears, right? Hopefully, I'm not going to have any of that in here, right, in this class, right? You're all going to be real tough. Just kidding. Sweat glands, sebaceous glands, even digestive enzymes, can be really important here. What do you think the prostate helps fluid with? Or what kind of secretions that help with? Like semen and sperm and things like that. So again, it helps. Prostatic secretion is really important for like the male reproductive system. You can also have, as far as sweat glands go, two main different types here. You have the eccrine and the apocrine. Usually you're going to think of the apocrine as being kind of the more the stink causing sort of glands there, because again, they're going to be located like in the axilla, pubic region, and again, a lot of bacteria can manifest there and cause smells and things like that. But again, just know there's different varieties that are present depending on which tissue you're dealing with, where at in the body you're working with them. Just some examples of, say, like a sweat pore, and again, notice how these are going to be closely interspersed here with like the hair cells and releasing things like sweat. So again, just an exocrine sort of thing, because again, we're releasing out of the body, versus when we say endocrine, what does that mean? You're keeping it within the body, right? So again, we talk about hormones like insulin, because that gets released through the bloodstream. That's an endocrine sort of gland, versus the pancreas can be endocrine, or it can actually be exocrine as well, because that's digestive enzymes. But we'll talk about that later. Okay. Next we have our connective tissue, and again, four major types here. You're going to find that connective tissue proper, right, which is going to be helpful. Things like the fascia and kind of keeping things together, but also cartilage falls in this category. Bone as well. Bones are obviously very important to maintain, especially when you get older patients. And then also the blood, technically a connective tissue, right? Hopefully your blood's not connecting too much there. It should be flowing pretty well. If not, then you're going to have some issues, but still technically considered to be connective tissue type. Again, you can have things like loose connective tissue here, and normally you're going to find that things like the upper layer of the skin is one place you're going to find this. It's loosely connected, so that it allows for different types of cells and different things to be able to connect together. So there's lots of room for things like blood vessels and nerves. It's kind of a hodgepodge of different types of cells that can all kind of link together. Again, that loose connective tissue can hold it all together there. First is something like a dense, regular sort of connective tissue is going to be more for things that need to be very dense and hold tight to their tissues. Things like tendons, ligaments can all fall into that category there. So I mentioned tendons bind what to what? Muscles to bone, right? And then our ligaments are going to do bones to bones typically, right? And then even our adipose tissue can be considered a connective tissue as well. Again, obviously, they're going to have those adipocytes where we're going to be storing most of our fats and things like that. Again, here's an example of like a loose connective tissue here. Notice how it's a very kind of hodgepodge, sort of different cells are going to be involved here. You have some adipocytes, you have some blood vessels, different things like that, versus like dense, regular connective tissue. It's very, very tightly packed, very well regulated there. Not a lot of room for other stuff to kind of get interspersed there. Here's an example of some adipose tissue here. Notice that, these can swell, they can deflate, depending on kind of what what's going on within the body. Again, what do we use a lot of that fat for? For energy, right? So again, if we're not using carbohydrates as our primary energy source, fat's going to be very useful, because again, fat has a lot of energy to it, and we'll talk about energy production later on in the class here. Also good for insulation, a lot of different things. But okay, so then looking at bone as a connective tissue, this is really important to help regulate this, because again, we have older patients. What's a disease state they may manifest that can occur, like think like little old ladies? Osteoporosis, right? What is osteoporosis? Metabolic disease of the bone. That's like the textbook answer, right? What do you tell your patient, right? Someone says, I have osteoporosis. What does that mean? Weakening of the bones. That's good. You have to get less dense. They're going to be more likely to break, right? That's one of the big things. Again, you want to be careful with your patients. Once they have a fracture, it can be very, very debilitating for the rest of their life. You see mortality and morbidity go up, skyrockets after these elderly patients get a fracture. So this, again, osteoporosis is a huge deal. But basically, what's the main sort of thing making up a lot of the bones? What's the main mineral? Calcium. And calcium can be super important. That's why I always say, like, hey, get a good calcium-rich diet, especially for older patients, even for younger patients. Have a lot of new bones being formed there. We're going to find there's lots of hormonal control that can go over that as well. Two main cell types that are important here are going to be the osteoblast and the osteoclast. Anyone know the difference? Yeah, so osteoblasts do the building up of the bone, osteoclasts do the breaking down of the bone, right? And again, this is really important because the bones are the main site for calcium storage. So when we become hypocalcemic, we have low calcium levels, where are we going to get that calcium from? From the bone, right? So again, if you have someone who's chronically hypocalcemic, you can end up taking too much calcium from the bone. That's where you get osteomalacia and eventually osteoporosis, right? Things like that can happen. Or you didn't have enough in your diet. Again, the bones are going to be the main place you're going to be getting that from. Basically, though, once you end up having that matrix, once it's formed, right, you're going to find that the osteocytes are going to be able to kind of solidify in there, and you're going to have these lacunae that end up developing. You kind of see here the osteocytes are kind of forming within there. Notice here there's going to be kind of an organized feature here. We have things like blood supply going to the bone, things like that. Very important for normal function there. Okay, and next we're going to have our organs we'll talk about. And again, this is just the basics here. We're going to go into more detail on these organ systems later on. So again, just trying to make sure we're covering the baseline here. So again, typically organs are considered when you have two or more tissue types that are kind of working together for different functions within the single organ there. So skin, largest organ you have, cover your whole body, hopefully. What's some functions that the skin provides? Insulation, protection, sensation. Yeah, so we'll talk about different nerves and different cells that can help with that. Right, so lots of things. Temperature regulation, another big thing it can help with. So again, they're all going to have specialized functions. So again, your gastric, say your stomach, can't perform the functions of the skin because again, they're just different cell types or different types of tissues coming together to make that organ itself. So again, very specialized. And again, we'll get into more detail on this a little bit later, but just know there's several layers here. Having the epidermis, the dermis, all of that are going to provide different functions. And you kind of see how the different cells are going to be involved here. We'll talk about, especially when we get to the senses, we'll talk about feel and touch. You have lots of different nerves that can respond to this. So, deep vibrations versus just tiny pinpricks can elicit different responses from different cells here. Very important here. Okay, so again, organs typically are going to be related to certain functions within the body. We have 11 interrelated organ systems we're going to be talking about here. And again, we'll go into more detail on how these different organs interact with one another when we get into their specifics. But here's the main ones we're going to be talking about. And again, not in this order necessarily. It's going to be more in an order that's going to be, we try to schedule these things out with other classes so you kind of get everything at the same time. So like, we're going to cover, usually this class is done in tandem with like anatomy. So hopefully we're going to cover the same stuff around the same time. It's not going to be perfect, but hopefully it lines up for you guys a little bit. So that way you're seeing the same thing in multiple classes and it kind of helps reinforce a lot of that. But anyway. Integumentary system, good for protection, thermoregulation, is where we see a lot of our skin, hair, nails, things like that. The nervous system, we already mentioned the brain, central nervous system, peripheral nervous system, all very, very important for regulation of lots of other systems, right? So endocrine functions here, we'll talk a lot about that later on in this section here. We'll talk about, control things like the thyroid, the pituitary gland, all of that, and it'll be very important. Skeletal system, muscular system. Our circulatory system is where we have like our heart, blood vessels is super important because again, what's one of the main causes of death in the U.S.? Cardiovascular disease, right? So it's going to be very important you have a good understanding of that. Talk about the immune system, how we're going to be actually defending ourselves against infection and other kind of foreign pathogens. Respiratory system here as well. We'll talk about urinary system, digestive, and then reproductive. And again, you don't have to memorize this list specifically, but just have a general idea of what the function of these different systems are going to be for, right? So if I were to ask you on a test question, I say, hey, what's the function of the skeletal muscle? You might say, move your bones, right? So again, little things like that. You wouldn't say, oh, it's meant to regulate blood pressure. Well, of course, the skeletal muscle doesn't really do that, right? So again, little things like that. You don't know the concepts of what these basic systems are going to be doing here until we get into more specifics later on. Okay, any questions so far? That was supposed to be my 1 hour mark, but you can tell I kind of go off on tangents and I'm a little slow sometimes. Anywho, so looking at the atom, not the atom, you're looking at the atom, but looking at the atom there. Usually going to be, and again, we're going to real basics here, so bear with me. Hopefully this is going to be repetition for a lot of you guys. Anyone taking chemistry recently? Organic chemistry? Right, so you may need a little bit of brushing off. I had to as well when I took over this class. But basically, cells, your atoms, made up of a nucleus. Typically, what's included in the nucleus? Protons and neutrons, right? Good. And then you're going to be surrounded by electrons, right? Okay, so you may be like, why the heck do I need to know this stuff? It'll become important in a second, right? I'll try to illustrate this. And again, based on how many protons there are, that will indicate what element you're dealing with, right? So for instance, when you're dealing with sodium, notice here you're going to have 11 protons. And then also, how many ever protons you have indicates how many electrons you're going to have, right? So again, those tend to pair off. So if you have 11 protons, you're going to have 11 electrons. Does that go the same for the neutrons? No, those can change pretty dramatically, right? And so again, looking at the atomic mass here, basically you're just going to, again, because electrons weigh what? Almost nothing, right? So again, we don't include that when we're talking about things like atomic mass, but we will include the neutrons in there as well, because neutrons do have some mass to them in addition to the protons. So whenever I talk about like the atomic mass of an element, I'm basically going to be including the number of neutrons plus the number of protons. So for instance, carbon, we have 6 neutrons, 6 protons, that equals 12, right? So the atomic mass of carbon would be 12, essentially. For sodium, it would be 11 plus 13 neutrons there, so it's 23. I'm sorry, 20. It should be 24. See, I am fallible as well. So there you go. Anyway, so it should be 24. But, so again, and that atomic number, when we talk about atomic numbers, that's going to equate back to the number of protons there are. So again, and that will kind of dictate where it falls on the periodic table of elements. Let's say carbon has 6, sodium would be 11 there. Yeah. Right, so again, looking at things like, hydrogen having here the proton in the center, again, we'll have 1 electron that's orbiting here. And why are these electrons important? What do you think? For bonding. For bonding, yes. So bonding is going to be super important. So yes, that is why we mentioned here in physiology, because again, appropriate bonding of these elements is going to be very, very important to see how normal physiological function kind of happens basically from the very ground floor up, essentially. Again, here you can see how these different orbitals, these different electrons are going to allow for binding of these different elements together, right? So for instance, and we'll talk about actual orbitals in this. But notice here, things like, again, this kind of goes back to your organic chemistry if you guys took that. But basically, certain elements can only make a certain number of bonds to other things. So for instance, carbon, because it wants to, every element wants to fill up that outside orbital to make sure it has a nice stable number of electrons, which is normally 8. You're going to find that, these elements can only make a certain number of bonds. So for instance, carbon only can make how many bonds? 4, right? So again, you can have carbon and you have 4 hydrogens around it, right? It's kind of the kind of the single simplest kind of organic molecule you can have there. Versus things like oxygen can maybe make 2 bonds, right? So you think oxygen, you think hydrogen, what do you get? Dihydrogen monoxide, right? So again, you have 2 hydrogens that can bond to that oxygen there, and then you got water, right? If you ever tell someone, hey, there's dangerous amounts of dihydrogen monoxide in the room, be careful, right? It's just water, right? You can trick your friends with your chemistry knowledge. Okay, anyway, so again, kind of going back to those orbitals to kind of dictate how many bonds you can actually make with these chemical elements, you're going to find these shells of electrons kind of surrounding these different elements, right? So you have the protons, neutrons in the center here. Normally you're going to have 2 electrons in this first valence, right? So this first shell is going to have 2 electrons. Which is important. You have like H2, there's 2 hydrogen molecules coming together. They fill each other out because they only have 2 electrons in the outer shell. Once you get above that, normally 8 is going to be the number that you're trying to fill up there. And so again, this is going to dictate how many are in this outer shell. It's going to dictate how many bonds it can make. Now, for instance, with neon, right? So neon right here, notice here it already has 8 electrons out here in its outer shell. So how many bonds do you think that can make? 0, right? Because it's already filled up, right? So again, a neon is considered what? Inert, right? It's a noble gas, right? So it's one of those things where it really doesn't make a whole lot of reactions because it's already kind of content to be where it's at. It's got its outer valence already filled up, right? So again, imagine like neon went into a bar and asked the bartender for a beer, and he says, "We don't serve noble gases in this bar." Neon didn't even react, right? This is the level of comedy you're going to be experiencing. It does not get any better from here, I can guarantee you. Anywho, but again, so that's important because again, you want things, in some cases, you want gases that do not react because reaction can be bad potentially, right? So for instance, One really good example is not necessarily with noble gases specifically, but I remember I was on rotations and I got to go view a surgery, right? And so you guys are familiar with laparoscopic surgery? You know what that is? Very minimally invasive. Basically, you're putting various holes into the patient, but you're not actually cutting them open. So, for instance, if you're doing like a laparoscopic cholecystectomy, right? So I'm doing a laparoscopic, so minimally invasive, getting rid of the gallbladder. Okay. So again, instead of having to open up the whole patient, which can be bad because that has a lot of scarring and infection and all kinds of issues, you just have these various holes in here. But one of the things they do is actually fill up the abdomen with a gas. Okay. They fill that up in order to get better visualizations that way, because normally the organs are all kind of laying on top of each other. You wouldn't be able to see much. But by opening it up, because again, laparoscopy uses cameras as well, right? So you can see inside the what's going on. So anyway, the surgeon was like, well, do you know what gas we use to fill up this patient with? And I was like, I don't know, oxygen. Why wouldn't you use oxygen? It's great. Oxygen is very reactive. Yes. Very reactive. Oxygen is very important for things like fire to occur, right? So again, when you're using something like a cauterizer to get rid of that gallbladder, if that belly was filled full of oxygen and he's using something that causing kind of a spark, guess what the patient would do? And that would be bad, right? Exploding your patient should be on the very bottom list of things you want to do with them. However, they use carbon dioxide. They use carbon dioxide, very relatively inert, because it is, again, it's filled up all of its valences. It's happy to be where it's at. So again, carbon with 2 oxygens there, and it does not react. So they can fill up the gut, basically the abdomen with carbon dioxide. It doesn't react with anything. They can use that cauterizer to get rid of the gallbladder, and they're set, right? So a little thing I felt kind of stupid because I was like, oh, just use oxygen. That's all smart. Not so smart, right? We also have, these, sometimes they can actually share electrons in some cases, which can be important, especially in cases of things like sodium and chloride, also known as table salt, right? But some of these bonds are going to be more permanent. So when I say I have a permanent bond between these two elements, what do you call that? Covalent, right? Because they're sharing valences right there. So for instance, when I have carbon H2O, right? This is just a water molecule. These are going to be kind of permanently bound together because it's a covalent bond. They're stuck there, right? Unless you were able to split it with some reaction. However, in other cases, we're going to find that you can have sharing of electrons, and that's where we're going to have what we call those ionic bonds, right? So again, with sodium and chloride, we're going to see that those are going to be able to share an ionic bond. That's going to be important because this is going to dictate how well things are going to be able to go in solution, right? And solubility of things is very, very important. So for instance, if you have the blood, do you want things to be soluble or insoluble in the blood? Typically soluble, right? You want things to dissolve within the blood, because if you have things that were insoluble, that could cause a blockage and cause an embolus, right? So one way that we deal with this quite frequently, at least from the pharmacy standpoint, is if you're giving calcium and phosphorus to a patient. Calcium and phosphorus really like to go, they like to bind together, and they will form calcium phosphate that goes out of solution. Basically, it is not going to be soluble in water whatsoever. So if I were to give that to a patient and give those two together, it can cause an embolus. It can cause embolus in the lungs and prevent oxygenation, right? So again, that's something I can actually do to actually actively harm that patient by giving wrong things that don't actually mix that well together, right? So again, solubility is going to be really important as we go forward and talk about these things in the blood. Solubility is good for the blood. Okay. So again, looking at those bonds, you mentioned, you're trying to fill those outer valences there. Again, with carbon, because it only has 4 electrons out here in the outer valence, you only can get 4 bonds out of that, right? So some things can make double bonds there, but typically 4 bonds, which you're going to be looking for. Whereas like hydrogen only has 1 electron in the outer valence, it can only make that 1 bond to something else, right? Here's some other examples, like with oxygen, notice here it's going to have 6 electrons out here in the outer valence. It only needs 2 additional ones, so that's why you can get 2 hydrogens that will bind to that and make water, essentially, right? So that way both those 2 hydrogens and that oxygen are now satisfied, their valences are full, and they're good to go. So water itself, very highly reactive or not very reactive? Not super reactive, right? And it's pretty content to be where it's at, right? Okay, and I mentioned covalent bonds are going to be a little bit more permanent. This is where they're sharing electrons there, so we kind of mentioned that already. You have things like H2 will form, or like water here. Again, these are going to bind. And again, when you're looking at how these are binding together, you can see that they can form polar or non-polar sort of bindings, and that can also be important as well. So for instance, with water, what do you notice here with the hydrogens? Is this kind of an equal, kind of even sort of looking molecule? Not really. It's kind of, you notice how it's kind of arched up here. So you notice how the 2 hydrogens are kind of closer together. That has to do with kind of the push and pull, the electronegativity there. However, this is really important. This is actually a very important concept here, that the hydrogens are kind of closer together. You kind of get this Mickey Mouse sort of look here, right? Because we're in Orlando. I had to bring it back to the mouse. Actually, I don't get paid by him anymore. falling out. Just kidding. But this is important because the polar nature of water is what allows for a lot of things to become more soluble in it. So again, whether things dissolve in water or not is very important because that'll dictate whether or not it's going to stay in solution in the blood, or if I'm making a drug, whether that stays in the solution. Because usually water is the basis for most everything, right? Anyone know how much of their body is made up of water? Yeah, roughly 75%, right? And like little kids, like infants, like it's even higher. So it's like 85% water, right? So water is very important to make sure that it's polar so it can dissolve lots of things, as we'll see here in a second. So again, here would be a non-polar covalent bond between, say, two hydrogen atoms. Here would be an example of a polar bond. And again, notice here, I'm not going to get all the specifics of it. Just know that because of this, because one end is going to be more negative versus one end more positive, you're going to, I'm sorry, this side's more negative, this side's more positive. You're going to notice here that allows for solubility to occur, right? And so again, water is a very good solvent for lots of things, but it's not going to be good for everything, right? Because what doesn't mix in water? Oil, right? Oil is a very good example of things that do not mix because that is a non-polar substance, right? Oils typically do not mix with water very well because, again, polar and non-polar don't really mix that well. Actually, a good example of that would be there's a drug out there. Anyone familiar with like lead poisoning? Right? Hopefully no one has it, but with lead poisoning, there's a certain drug we actually give, and the drug is so insoluble we actually put it into peanut oil. And peanut oil is not very miscible with water. It does not solubilize in water very well. So we actually have to give this as an IM shot. We can put it in the muscle and allow the drug to be absorbed passively. But if I were to put that into the bloodstream, it causes an emboli because it wouldn't really go into solution. It would get up in the lungs and cause all kinds of problems. So again, solubility, very, very important, especially when you're dealing with the bloodstream. You want to make sure things are flowing appropriately, right? Anywho, I mentioned ionic bonds. This is where they're going to be not necessarily sharing an electron, but more donating an electron. So this is when you can see like sodium and chloride. When they go into solution, you're going to find that they actually will be able to donate those electrons to one another. And then now both of these are satisfied here, right? Sodium by itself, very reactive element. When you put it with chloride and they now share that ionic bond, they're good. Sodium chloride not all that reactive in and of itself, right? Which is good because we have a lot of salt and chloride, or sodium and chloride in our body, right? Okay. All right, so I mentioned water, formed that polar covalent bond. It's a very good solvent, so lots of things like to go into solution in it, which is good for us because we want things to be solubilized. Now, if something does not like to be soluble in water, what do you call that? Hydrophobic, right? So again, we're going to talk about this quite a bit. So hydrophobic means it does not like water. Hydrophilic means it loves water, loves to be solubilized in water. And so that's an important concept, especially when we're talking about things like absorption of things through the skin, right? Things are going to be more, we'll also talk about things that can be lipophilic versus lipophobic. But again, these are going to be two concepts we're going to be seeing quite a bit, especially in the farm stuff. So this will come back later. So hopefully you'll memorize that. But basically just know that like when you see a sodium chloride crystal get solubilized in water, notice here how the water is going to be surrounding, positive and negative like to attract one another, versus here with the chloride, it gets surrounded by water there, and that goes into solution. That did not occur, then you would see the salt and chloride would not go into solution. You would see it just kind of settle out on the bottom if you were to pour that into water, right? Okay. So again, just another example of showing how the water is kind of surrounding these molecules and this goes into solution. Note that everything, that if you were to say put salt into water, can I just add infinite amount of salt and it keeps solubilizing? You can't exhaust that, right? So again, you can run out of amount of water to solubilize this sodium chloride. That's why you see things will settle down at the bottom if you don't, if you keep adding more and more to that solution there. Let's see. Now you can see, now this is actually important for acid-base balance here as well. So water itself can actually become ionized when it's in solution here. And so normally what you're going to find, this is going to be the basis for pH essentially, right? So normally what you're going to find is water is going to maintain an equilibrium between being in this H2O sort of form here. We're getting pretty stable, but some of it will dissociate. And again, you're going to find that you're going to have OH plus this lone hydrogen molecule. And based on the amount of hydrogen molecules that are going to be there kind of on their lonesome, in the solution, you can find you can change the pH pretty dramatically, right? So we said normal, what's a neutral pH? 7, right? We're going to see that we can have certain fluids that are going to be a lot more alkaline, which means more basic, which means higher on the scale. We have some solutions are going to be a lot more acidic than that. And it goes back to this dissociation of and ionization of water in solution there. Again, neutral solution should have a pH of 7. As you increase the number of hydrogen ions, that makes it what? More acidic, and what does that do to the number scale, pH? Goes down, right? So for instance, when I have the stomach has special cells that will just pump out hydrogen ions into that solution. That drives the pH down pretty significantly. So anyone know what the pH of the stomach is? Yeah, so very, very low. However, you can have other solutions where if you have fewer hydrogen ions and you have more of these OH, these hydroxyl groups floating around, you'll actually drive the pH up, right? And again, it's very important to keep our pH in certain ranges because you can have big problems that happen otherwise. We'll talk more about that a little bit later on. But just some examples, looking at these, I don't want to run out of time here, so 2 minutes. So again, pure water, blood is a little bit more basic. A little more alkaline than you would see just natural pure water itself. So I mentioned a normal serum pH is around 7.35, 7.45. Again, not a lot of margin for error there. If you get a serum pH below 6.9, the patient's not doing very well, right? So again, not a big shift there. Anything below 6.9, they're probably not going to do well overall for those patients. But things like coffee, orange juice, things you might have consumed this morning tend to be pretty acidic, right? Versus things like bleach, detergents tend to be more on the basic side of things. And so it's important to keep this balance appropriate. And in some cases, like for instance, if I have a patient who comes in and they're very acidotic, right? So their pH is too low, say they're like 7.2, I can give something, an alkalizing solution, and try to increase their pH. So for instance, sodium bicarbonate. Bicarbonate tends to be more basic. I can give that to the patient and try to increase their pH to get it back into a normal range. So there's lots of ways we can kind of monkey with this. Anyone know what organs are really important for regulating pH in the body? Kidneys are very important, right? Yeah, they regulate bicarbonate typically. The lungs are the other big one, right? Because again, I'm blowing off carbon dioxide. We'll get into that much more in detail later. But think kidneys, think lungs, those are very important to help regulate our serum pH. Anyway. Again, just some other solutions here. You can kind of see the different ranges. pH paper, you may actually still use this in clinical practice. I use it from my standpoint and from a tox standpoint because, again, if I have someone who gets, say, for instance, drain cleaner. Anyone know what a drain cleaner usually made out of? Like Mr. Plumber, Drano.
Very basic.
Yeah, usually a very basic solution because it helps to dissolve hair and all that kind of gunk that gets caught up in your pipes. But it's very, very basic. So you usually have a pH of like 11, 12. If that gets into somewhere like the eye, it's very, very irritating. And so we actually have to do is flush this patient's eyes out pretty copiously, and we'll check a pH paper and actually we'll dip it down into the cul-de-sac there in the eye and check the pH. So again, you may find litmus paper. You may have used it once or twice in your chemistry labs. It actually comes back in clinical practice more frequently than you might think. Anywho, again, when you have a solution with more hydroxide ions than hydrogen ions, typically it's going to be a basic solution. pH is above 7. If you have too many hydrogen ions, it's going to be an acidic solution, right? Anyone remember dealing with the Henderson-Hasselbalch equation? It's going to come back to haunt you in farm. Just wait. Just to give you a clue. Okay, so I mentioned 14 is going to be the highest pH you can have there, most basic. 0 would be the most acidic. 7 is going to tend to be on the neutral side of things. So any questions on that? Let you guys go. Any questions over the whole section so far? Okay, good job. You guys survived your first class. It's all downhill from here. Not in terms of quality. It's probably uphill for a while. But then 8 o'clock tomorrow, it's going back downhill again. All right, I'll see you guys tomorrow. Wait, is it tomorrow? Yes, tomorrow, I believe. See you guys then.